Welcome everyone to High Rounds on this lovely Friday. Today we have Dr. Elliott Welford, and I had to go back a year ago to find a bio, but it's a good one. So we're gonna get a fun fact in here as well. So Elliott did medical school at the University of Mississippi, graduated in 2015. He then did his internal medicine residency at the University of Cincinnati as well. And there he stayed on to be chief resident at University of Cincinnati. And then he came out here in 2019 to do his infectious diseases fellowship. He is now in his third year. He's doing some really cool work with Dr. Susan Little. And I'll let him talk to you about it more, but he is today going to be talking about some work related to public health and the economic impact of gonorrhea chlamydia testing, which I'm sure we're all very interested to hear. And I'm going to give one fun fact that may have changed now because this is from a year ago. The first part clearly wouldn't have changed, that he took 13 years of piano lessons, loves playing piano, and at least as of a year ago was looking for a keyboard. Elliott, did you get your keyboard?
No, I didn't.
All right, well, this is a plea to the group. If you know of a keyboard, send Elliott a message and maybe you can get it all hooked up.
It would have been perfect timing.
But I'll turn it over to you. Elliott, I'll keep an eye on the chat and just interrupt you for clarifications or if it just seems appropriate. And I will try to give you the 10-minute heads up so we can have some discussion at the end.
Okay. Yeah, it should be pretty I don't have a ton of updates, and hopefully I'll be able to be done on time, a little bit before time. So okay. Thank you for that, Jill, that introduction. Super embarrassing about the fun fact. I really need to change that. But hi, everybody. I'm Elliott Welford. And yeah, like Jill said, I'll be talking about really my updated work in progress, really. I'm getting close to the end and writing, and hopefully we'll be submitting this for publication soon. But the work that I'm specifically looking at is testing, rapid testing specifically among men who have sex with men, gonorrhea and chlamydia testing, and looking at cost and public health benefit of this, specifically looking at infectious days averted. So why is this important? I mean, I think we all know this, but just to kind of be explicit about it. So looking at chlamydia rates in the United States for the past 2 decades, really, they've been increasing. Now, rates of chlamydia among women has always been higher than men, and that's thought to be because of a larger number of women that are screened for chlamydia compared to men. What I want to bring your attention to is the fact that in the past 5 years, really, rates of chlamydia infection among men has been going up about 32.1% in the past 5 years. This increase is believed to be, not really sure, but believed to be at least in part of increased screening among men, specifically men who have sex with men at urogenital sites and then extragenital sites as well. There's also some thought that there's increased transmission, again, specifically among men who have sex with men. It's likely a combination of the two there, but rates of chlamydia in the past 5 years are really kind of taking off for men. So that's something that catches my eye. Rates of gonorrhea in the past two decades, different story here. The rates among men have pretty consistently been higher than rates of gonorrhea among women, but really, if we take a look at the past 4 or 5 years among men, starting to really take off for gonorrhea. The rates are increasing 60.6% for men. That's a rate increase of 139.7 per 100,000 to 224.4 per 100,000. And here with gonorrhea, it's a pretty clear issue that the rates among men who have sex with men are really what's driving this kind of really rapid increase in the past 4 or 5 years. The magnitude of increase among men who have sex with men is increasing. The rate of gonorrhea among this population is believed to be 42 times higher than men who have sex with women. So this is the population that I think MSM for both gonorrhea and chlamydia, specifically in the past 5 years across the entire United States, is a population that needs to be focused on. And so that kind of started my interest in looking at gonorrhea and chlamydia. What do we do about this? How do we have an impact on this epidemic? And I wanted to start really at the basics of looking at testing. So what's our kind of standard of testing for gonorrhea and chlamydia in the United States and really across the world? And we all know this is nucleic acid amplification testing, great technology, but there's issues with this. And we all know you collect a specimen in your lab, in your clinic, you send it usually off-site to the lab, because this is a kind of a behemoth of a machine that's capable of running a lot of specimens at one time. So the specimen is collected, sent off-site. The specimen often sits around because you batch these, the lab will batch these together. So it sits around, but then even when the test is being run, the machine can take 5-6 hours to give a result. That gives you a turnaround time of about 1 to 4 days. And I say turnaround time, and specifically that specimen collection until test result. This isn't the patient being treated. So there's a big kind of window here for your even getting your test result, and then you have to bring the patient back in to be treated. Then the next question that I have is, you get this turnaround time. How long does it actually take you in the United States to treat somebody for gonorrhea and chlamydia? And this in the literature really is not well established. I know this data exists within kind of little pockets in public health, but they're not really publishing this data. If you go into the literature, really the most recent kind of decent study looking at time to treatment for gonorrhea chlamydia is back in 2005, and it's not really our population, right? This is looking at time to treatment gonorrhea chlamydia among women. This study looked at 3 different cities, public health departments in 3 different cities across the US, San Diego, Los Angeles, and Washington, DC. And there's a wide range of time from specimen collection until shot in arm or pill in mouth. And San Diego initially reported a median time to treatment of 14 days. After they made some protocol changes, they were able to get that down to 7 days. Los Angeles reported 8 days for time to treatment, and Washington, D.C., 18 days. And so really a wide range here, and nothing, recent and pertaining to our population in the literature. Why is this important, right? So we all know this. If a patient is tested for an STI, they're waiting for treatment, waiting on a result, they're still having sex. And so we kind of innately know this, I think, but in a 2006 study in England looked at about 3,200 patients and showed that about 45% of men and 58% of women continued to have sex while waiting on treatment. And not a small proportion had sex with multiple partners. And so this is really an issue, right? This time to treatment is really a period where people are infectious and likely lending themselves to the forward propagation of gonorrhea and chlamydia. And so it really looks like a place that needs to be looked into. So how do we do this? How do we change this with our testing techniques or testing modalities? In 2012, the FDA approved the first rapid test for gonorrhea and chlamydia. And I'm not going to call this a point of care testing. This test, the Cephia Gene Expert, it's in the clinic, but it's not point of care, because in point of care, it needs to give you a result while the patient is in the clinic. This doesn't happen. The test result for this machine, you can get a test result within 90 minutes. But the benefit of this is it really, you've got this machine now in your clinic. You take away the need to send a specimen out to the lab. You get a rapid test result. There's no need to batch this, right? Little cartridges, you have a specimen, you can put it in, another one comes along, you can put it in the next one. You don't have to batch this. And so it really kind of decreases time from specimen collection until result, and then potentially until decreasing your time to treatment. But not really sure about that. So I wanted to look into the literature to see what people have done, what their reported time to treatment, how that's changed after implementation of this testing modality. United Kingdom, they, using standard testing for gonorrhea and chlamydia, reported about 8.7 days for time to treatment. After implementing rapid testing, they were able to get this down to basically same day treatment. The New York City Public Health Department, similar situation with standard testing, their time to treatment was about 8 days. And then with rapid testing, they were able to push that down to 2 days. The next question that I had is, how much is this going to cost? And these studies do not really exist in the United States. The most of the, there's a few studies in general, but the ones that were able to find were in the United Kingdom. And they did show that these rapid testing is cost effective. The first study looked at implementing rapid testing at multiple genitourinary medicine clinics in England, and they showed that rapid testing cost $143.4 million versus standard testing costing $159.53 million. They also showed that there was an increase in 46 quality adjusted life years. And another study looking at one specific clinic showed that you can save money by reducing the number of partners needed to be treated for gonorrhea and chlamydia if you implement rapid testing. But that's in the United Kingdom. So there are knowledge gaps, specifically knowledge gaps here in the United States, and specifically among men who have sex with men. So it's really unclear in our population, this high-risk population. Again, this is the population that's seeing a disproportionate increase in the rates of gonorrhea and chlamydia. In the United States, we're not sure if there's a benefit of using rapid testing. And really, in the United States, not sure of the economic impact of this testing. Yes, the UK showed some cost savings, but that's a completely different system, and not necessarily looking at, again, our high-risk population. So cost effectiveness studies are lacking in the US. And then studies of how to implement this, right? Different healthcare system altogether. What would it look like to put rapid testing in a US public health department? And so that brings me to what I wanted to do for my first research project, and just really kind of dive in to look at the public health impact, the economic impact of this testing within the MSM population. So my first aim was to look at time to treatment for rapid gonorrhea chlamydia testing at a specific clinic here in Hillcrest, the Good to Go clinic, and compare that to historical data for time to treatment for routine gonorrhea chlamydia testing. Within this, I wanted to then do a cost effectiveness analysis looking at the cost per gonorrhea chlamydia infectious day averted for rapid testing, comparing that to routine testing, and then look at implementing and maintaining rapid testing within the San Diego Department of Public Health, or how it's officially called, the Public Health Services of San Diego County. How I did this. So just to make it clear, I think most people are aware of the Good to Go clinic. This is our Hillcrest Express Sexual Health Clinic. And I want to be sure to highlight that this is a sexual health clinic, and it's a bit of a paradigm shift from how we normally think of classic STD clinics, right? So you go to a STD clinic, the presumption there is that you're positive, right? Most people go to STD clinics, they have symptoms or they have an exposure, and the assumption is that they're positive. At something like the Good to Go clinic, the sexual health clinic, people are really encouraged to come in every 3 months for kind of asymptomatic testing to see if they're good to go. And so the assumption here, these are asymptomatic people mostly, and the assumption is that they are negative. So this is an express clinic. People come in, they are asked risk assessment with a questionnaire, and they're in and out within 30 minutes, and they have 6 different STI test results, and most of them are sent to them the same day, either via text message or email if they are okay with that happening. Just to kind of be thorough and show you a little bit more of the stuff that Good to Go does. If based on their risk assessment, if there's indications, they're offered immediate PrEP. What happens if they're positive for STIs? Well, if they're positive for HIV, they're offered immediate treatment at the AVRC. I say immediate, it's at a separate location, a little bit of a delay there, but they're offered treatment at the AVRC. And what I was interested in, what happens when this rapid test comes back within 90 minutes and they're positive for gonorrhea, chlamydia, or other tests. Similar situation, they're offered really fast treatment at the AVRC for those STIs. So what I did is I did a retrospective analysis of all adult men who have sex with men and transgender female who underwent rapid testing for gonorrhea and chlamydia in the time period from the opening of Good to Go in November of 2018 until its closure. It's open again now, but until its closure with COVID in February of 2021. I noted all of the STI test results of the participants during this time period, and then I noted their symptoms. Symptom data was gathered when people are positive, if they came into the AVRC for treatment, which I'll show you is the majority of the patients. They came into the AVRC for treatment, they were asked a questionnaire, and that's how we were able to gather symptom data. And then I looked at the time to treatment. And time to treatment is from specimen collection until treatment delivered. The economic evaluation that I did is really, it's a micro costing. So it's starting with everything that possibly can go into specifically testing for rapid gonorrhea and chlamydia. So micro costing, top down, ingredients based. This includes equipment, building space, staff, and really, again, everything that you can think of related to this type of testing. I broke it down into fixed costs, which are capital cost, and that really is just the cost of the machine. Then outside of fixed costs, we have recurrent costs, and that is personnel versus non-personnel. All of this is used to calculate a total unit cost per test for rapid gonorrhea chlamydia testing. Comparing this to the data that the Department of Public Health gave us. And so they supplied us with a very detailed total unit cost per test for standard routine testing done at the Department of Public Health. And I looked over that to make sure that their inputs were the same as our inputs to make sure it was a comparable costing strategy used, and it is. The cost effectiveness analysis that I did is in the form of an incremental cost effectiveness ratio, and that's where the numerator is made up of cost of your intervention and cost of the control. And then the denominator is the effect, whatever effect you want. And in our case, the benefit or the effect that we put on the bottom is infectious days averted, and that's used from time to treatment using rapid testing and time to treatment in the literature based on routine testing. And that gave us our cost effectiveness analysis. So here our demographics just highlight the population, the target population of Good to Go, which is MSM population, transgender female, and the Latinx community. So 98.2% of our participants are assigned sex at birth. A pretty comparable chunk of our participants are Hispanic, 34.9%, and then over 90% of our participants are gay or bisexual. So this is in our testing window here, the data generated as far as STI test results. Between November 2018 and February 2021, we have 2,333 individuals that were tested at or that came to Good to Go clinic. About 63% of them only had one visit, but then over a third of the patients have multiple visits. That's 2, 3, over 4 visits here. And so those 2,300 individuals gave us 3,712 STI test results. About 16% of those test results were positive at least for one STI. And then 76.4% of these participants were treated at the AVRC only. So we have kind of full picture data on these patients here as far as positive STI test results. Here is a summary of the STIs, and I want to focus on here. This is chlamydia at any site, and that is the most likely STI to be positive among our cohort, and that's 99.8% positive among those successfully screened. Looking at the different anatomical sites, rectal, oropharyngeal, and urethral, rectal chlamydia is again, 9.1% positive among those successfully screened. And it really drops off for oropharyngeal, 1.6% positive, and then urethral, 3.03% positive. So rectal chlamydia, high proportion of our screened patients were positive for rectal chlamydia. Going up to gonorrhea, gonorrhea at any site, about 6.6% positive, and a pretty equal split between the diagnosis of rectal and oropharyngeal gonorrhea, about 5%. Urethral gonorrhea really represents a minority of our patients, 1.1%. And so highlighting this, we go on to our symptomatic data. And like I said, rectal chlamydia here, 9.1% positive, a really small amount, a small proportion are symptomatic based on our symptom data, about 13% symptomatic for rectal chlamydia, and not a small proportion. This represents the most diagnosed among gonorrhea and chlamydia, rectal chlamydia. And same situation with rectal gonorrhea and pharyngeal gonorrhea. 33.3% for pharyngeal gonorrhea reported symptoms, and then 17.9% had symptoms for rectal gonorrhea. And again, this represents about 5% positivity among this group. Our time to treatment using rapid testing, it resulted in a median time to treatment of 2 days with a range of 0 to 16 days. This based on the literature review using a range of time to treatment for routine testing of 7 to 14 days as kind of a range where that likely somewhere in the middle or somewhere in this range is the true time to treatment for routine testing. Using that data and our generated data for time to treatment, you get a infectious days averted of 5 to 12. And then assuming that across each of these infectious days, the likelihood of transmitting gonorrhea or chlamydia is the same, this results in a reduction in transmission of about 71.4% to 85.7% using rapid testing. My incremental cost effectiveness ratio that I did, or the cost effectiveness analysis, not surprisingly, the cost effectiveness changes based on the number of tests that you run a year. And so what I wanted to do is really focus here. You've got incremental infectious days averted on the bottom and then cost up here. But this range is where I want to look. And that is because, again, with rapid testing, the number of infectious days averted compared to routine is probably 5 to 12, somewhere between 5 to 12. So on the lower end of the spectrum here, if you run 100,000 tests a year, and if you run 1,000 tests a year, the cost effectiveness ratio is $5.16 to $12.30. Swinging over on the other side of the spectrum, running 100,000 tests, running 1,000 tests, you get an incremental cost effectiveness ratio of $2.15 to $5.12 per infectious day averted using rapid testing compared to routine. What does this look like trying to scale this up in the county public health system? So just to kind of go over, the Department of Health in San Diego has 4 different STD clinics. We've got North Coastal, Central Region, Rosecrans, and then the South Region here. And so we got data for the total number of tests run at the county public health prior to COVID. We have about 5 months of data from January to May 2019. Again, this is pre-COVID, and we have the total number of tests here. Really, the busiest location is Rosecrans with South Central, North, or South Region, North, and Central Region having a lot fewer tests. I calculated a daily average at each of the locations just to be able to decide which of the rapid testing machines would be needed to sustain their testing needs at each of the locations. And we came up with cost of implementation and then annual recurrent costs for putting in these machines and running rapid testing at all of the clinics within San Diego County Public Health. So cost of implementation is really just the cost of the machine required. And like I showed, every center except Rosecrans has a few number of tests that they are required to run daily. And so they really only need the smallest gene expert machine. And that's the cost of this machine here, $44,000. Rosecrans has a bit higher traffic, needs a larger machine. And so this is the cost of, I think, the 16 cartridge, which is what we use at Good to Go, giving us a combined cost of implementation about $307,600, and then annual recurrent cost for rapid testing of $621,000, let's say. So there's some cost that comes with this, and I don't think that's very surprising.
Elliott?
Yes.
Just really quickly, there are a lot of questions, but I don't want to interrupt you, but just one thing I think that is relevant to what you just said is explaining how the staff time is put into the model. And for what you just showed, do the recurrent costs, does that include staff?
Yes. So the how staff plays into the cost is the salary basically of the tester. And then we gave them, I interviewed them first of all to ask how much time they think they spend doing the parts of running the test. And then I gave them a log book, and they recorded their actual testing times specifically spent doing rapid testing. And so this was averaged out over a period of about 2 weeks. And that came up with the time spent, and then I multiplied this by their salaries. And then what was the other question?
Sorry, can I just follow up? Jill, sorry, Jill, this is Nettie. I asked that question. Thank you. I'm listening intently for thinking about implementation. I was wondering about the staff time saved. So, you know, in a routine testing situation, there's actually quite a bit of staff time spent following up, trying to track down the patients to get them back in for treatment. And I'm wondering how to incorporate that into the model so that we get, you know, sort of credit for that when you think about the cost savings of doing rapid testing.
Yeah, and so great point. Anything that wasn't, we only put in the staff time and estimated the cost of them again actually running the test. So contacting these people, contacting all of that, it's not incorporated into this model.
Contacting and then the nurse visit or the provider visit or whatever it is.
We assumed that this was equal in both. Like you know, we assumed that it was equal whether you're using routine or rapid testing, right? You still have to have a nurse. You still have to bring them in for treatment. We said those two were equal, and so we kind of dropped those off.
Okay.
Yeah, we're looking for differences really, and that's running the test and specifically. The other question, Jill?
There are more, but you should go back. We can get to things that was relevant to what you were just talking about.
Perfect. So the cost of implementation, annual recurrent cost in the public health department. Then I calculated the cost effectiveness analysis, this incremental cost effectiveness ratio for rapid testing within San Diego Public Health. And this takes into account the number of tests that each site and cumulatively they run a year. The cost effectiveness ratio is $2.35 to $5.64 per infectious day averted. So this is a positive number, right? So it costs, based on the analysis that we did, this is a more beneficial testing modality. You decrease infectious days, but you do have to pay. And this is the case, I think, with a lot of new technologies. So just kind of moving into the final thoughts of my research right now, and this is kind of a hodgepodge, and so we'll see what other people think as well. And obviously our data highlights the large proportion of who we know asymptomatic infections, specifically among our MSM population. And and really underscores the recommendation, appropriate recommendation by the CDC, is that we need to be screening these at-risk patients at the appropriate anatomical sites. We did show a public health benefit by decreasing forward transmission of gonorrhea and chlamydia with rapid testing by up to 85.7%. And like I said, this was our cost effectiveness. You know, we have a benefit here, but this is a new technology. It's a good technology, but it costs based on our analysis here. And so there could be, you know, what we did not put into this is the cost of breaking up, interrupting transmission of gonorrhea and chlamydia, and then looking at the preventing the consequences of untreated infection. And so while right now we've got a cost associated with this, if there were models showing what happens with the transmission rate, the prevention of consequences here, and perhaps you could actually have a cost savings. The implementation within the public health department, again, here's the cost effectiveness ratio that I came up with. When a technology or a medical treatment is more expensive but has a benefit, the way that you decide if it's cost effective is looking at a threshold of willingness to pay. And so what that means is here's my cost effectiveness ratio, $2.35 to $5.64. If someone somewhere said, well, I'm willing to pay $7 per infectious day averted, well, here we would, our data show.
If you have a UCSD ID, it's evaluating on COVID vax and yada, yada, yada. Anyway.
Is not, okay. So if someone somewhere said $6 per infectious days averted, I will pay that. Our data suggests that then rapid testing would be cost effective, but that's just the issue is in this situation, there is money that has to be spent for it. So someone has to say, here's my threshold of willingness to pay in order to say, okay, it's cost effective. Anything less than the threshold of willingness to pay is cost effective. Anything over that is deemed not cost effective. Some thoughts I have on the limitations of my study is that our participants are not randomly selected. So obviously these may not be generalizable to the larger MSM community. Behavioral data that we had, so risk data, symptomatic data, this was all by questionnaire, and so it's obviously subject to recall bias. Our cost effectiveness analysis that we did, we reported the denominator being infectious days averted. More commonly, this is reported as dollars per quality adjusted life year or disability adjusted life year. You can use any effect for the denominator, and so we use our infectious days averted, but more commonly quality adjusted life years are used, and so perhaps this makes it a bit more difficult to interpret. But even if we were to report cost per quality adjusted life year, the issue remains that in the United States, we don't have official thresholds of willingness to pay or thresholds of, X amount of dollars per quality adjusted life year is deemed to be cost effective, unlike other more centralized healthcare systems. The United Kingdom, Canada, Australia, we have kind of unofficial thresholds in the US, but it doesn't really exist. And so even if we were to report in quality adjusted life years, our cost effectiveness analysis, I'm not sure how easily interpreted that could be here. And then future studies. So I'm talking about gonorrhea and chlamydia and at high rounds. And so you kind of bring it around. The overlapping of the epidemics of gonorrhea and chlamydia and HIV, or bacterial STIs and HIV, is really what interests me. And I think the future future studies can be focused on more complex modeling that we did not do. So I think looking at the impact that rapid testing and rapid treatment of gonorrhea and chlamydia has on the acquisition and transmission of HIV. I think that's really fascinating, right? We know it's well established among specifically MSM that having gonorrhea or chlamydia increases your likelihood of acquiring and transmitting HIV. And so I think that being able to model site-specific gonorrhea chlamydia transmission and the effect that this has on HIV acquisition and transmission, and then looking at what happens when you put in rapid testing and treatment, I think that's really fascinating. And then along the vein that I did, looking at cost effectiveness here, I think the next step is, again, looking at more complex dynamic modeling of site-specific gonorrhea chlamydia transmission, and then taking into account modeling what happens with these transmissions and then doing a cost effectiveness analysis of rapid testing. I think it's more complicated, but to do that, then perhaps you could have a different result for whether or not rapid testing is cost effective. So those are kind of my final thoughts, and I'm wrapped up here, my references, and I'll take questions.
Elliott, you can pull up the chat if you want. There's a lot of dialogue. There were a few things I was going to point you to, and then I was going to try to have some other people speak, because I think we have a lot of experts here who work in different arenas that could potentially offer some additional thoughts. Yeah. So one of the just questions that I answered, but I just wanted to make sure I had it right. There was a question about good to go and where treatment for STIs occur. And I said that all happened at the AVRC.
Correct.
And that's because it's not a licensed space. I know that was I don't know if Susan wants to comment on that. I explained that, but everything happens elsewhere, not exactly at Good to Go. That was just a quick question I wanted to answer. Let me see if there was anything else before I was gonna see if, sorry. I mean, Nettie wants to start this. That's the big thing. And I don't know if Nettie, you want to talk more.
That's the point. That's the point of doing
I think though there's some major issues with it. Go ahead.
Yeah, there are. So sorry, I just jumped the gun. Like, this is because I've been thinking about this for so long, because, and that's why I asked about what you put in the model. So I have an administrative hat and a clinical hat, right? So I treat a lot of gonorrhea and chlamydia, but also just looking at running the clinic, we spend a lot of time going around in circles with these patients. And that's why I would really recommend that we think about ways to study this that includes that activity. So when someone comes in and they have symptoms, those guys don't really count because they get treated immediately. Exactly. So we're talking about screening, right? So we do a ton of triple site screening. And so most of the time it's just click, 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 negative, negative, negative. Those positives, there's first of all the risk of missing it in the inbox of the provider. So, but hopefully our nurses are watching. So there's a lot of nurse time to monitor those results. So our nurses are scanning all the inbox every day, make sure they don't miss anybody. Then we got to call the person back in. Then we got to send a message to the clinical team that says, hey, this person has chlamydia and is untreated. Then everybody has to keep that on their radar until we get that person back in, which might be immediate or might be not immediate. And so then you've got a lot of handoffs of time and everything. So that's something I think that's harder to measure, but is really important. And I think we could actually look at the staff time. To me, I feel like it would be cost savings, at least per case. And then the other question I think is really looking at, who will pay for these. So let's say we say, okay, looking at staff time, it is actually maybe cost saving to do your screening this way, but it's so expensive, but you're saving that staff time. But of course the insurance doesn't care because they don't have to pay for point of care testing. So how do we lobby our insurances to say, if you want us to prevent HIV transmission using the most effective technology, why are you paying for the one that doesn't work, but you won't pay for the one that basically saves the whole system money that does work? So that's some advocacy we have in HIV, is that just the structure of payment. We can't get paid for point of care testing, even though, if I send it to Quest, there's reimbursement involved for them. So I think that those are some of the issues with HIV, but I think we as a community could solve that. But maybe the first thing to do is to do a study within an FQHC or within the own clinic, or looking at the clinical site and really trying to track that staff time to make the argument, because Ryan White also pays my staff time. So it's the same system. It would make sense, but we have to get creative on how to do it. But I'm really motivated to do it.
Yeah. Interesting.
Yeah, Nettie, I mean, this goes for so many things, right? Where we know the end point is, or one of the big issues is insurance. And that's why so much of this can happen in the context of research. But how do you implement it in, the American healthcare system, which is so complicated and makes it so that we can't do the things that we know would ultimately be beneficial, and it takes advocacy. And over what period of time will that actually happen? Darcy asked a question about bringing back in the patient for chlamydia treatment versus just sending in a prescription. I'm assuming you just meant for gonorrhea or syphilis, and not chlamydia, Nettie, or anyone. I remember those two.
Well, yeah, I mean, it's staff time either way. Like, either they have to track the patient down, send the treatment, make sure they took their treatment, or we have to bring them in if they need a shot, or if it's, so it depends on the thing you're talking about. And I agree, syphilis probably takes more staff time because we got to bring them back in. But like, even for gonorrhea or chlamydia, you have to maybe, if they only did the urogenital screening, and then you need to bring them back in for triple site screening while you're treating them, or if they have gonorrhea and they needed a shot. So I wasn't being very technical on my description, but there's staff time involved in all of it.
Yes.
The other thing that I can think of that for me at least has been a killer are the new pharyngeal chlamydia guidelines, which require or recommend a test of cure within 7 to 14 days. That in itself, like I've created a smart phrase to make it as clear as possible, both to staff and to patient. It still gets bungled all the time. And I have to sort of stay on top of it. And if you were just diagnosing it, if you knew you had a pharyngeal chlamydia, not chlamydia, sorry, pharyngeal gonorrhea. I'm so sorry. Pharyngeal gonorrhea. I don't want to confuse anyone. Thank you, both of you. If you knew it that day, you could say, all right, we're scheduling you for 14 days or whatever it is to come back in for your swab. And that's a whole other thing. Could you send someone with a swab that they mail back in? I've discussed that with Elliott. How do you actually do that? But that to me has added a layer of complexity, with this, when you actually get them in and then you have to explain, but you have to be back again and all of this time. Sheldon has raised a few different interesting points. He's also involved in point of care STI testing. And Sheldon, I was wondering if you could talk about the two different systems that you've used.
The thing is, but I think what I'm hearing there is there's a lot of time to manage the machine and stuff like that. And so that, the solution, a bit of that is new technology. And so that's why, there's the Bing system, and then there's this system that we just got FDA cleared, which is called the sexual health test from Whitby Medical Aids. But we did it. I did the pivotal study for that. We published in Lancet ID in May, and it was for self-collected vaginal specimens in women. Is how we got the FDA indication for. So it tests for chlamydia, gonorrhea, and trichomonas. So I think that's now cleared and it's going to be available. So I think, but the simplicity of the system is it's a single-use device. You get a little pipette, you get your sample, you drop it in, you plug it in, you turn it on, and you leave it for half an hour, and you get the result. So it's a lot faster. There's much less hassle because you don't have to manage the machine. So in many ways, that's, if we go to those kinds of systems, you're going to have much less of that extra time that you need. It's almost like doing a pregnancy test, right? It's getting to almost that level. So I think that really brings down the workflow issue, because the problem is workflow. And then, as you guys have been talking about, getting it billed and reporting it and putting all that into the system needs to be worked out. And if you have, of course, if you do it for an indication that isn't, if you have to do it for a male pharyngeal specimen, you would have to do all the verification tests. So we've been we're looking, and we did put in an application to do a sort of a study for that. And we're going to go after that again to try and do that, hopefully locally here. But I think that there is better solutions too. And so that should bring it. I think the biggest issue is going to be the workflow and the billing issue and reporting it into systems. So, but yeah, I could send that reference to people if they want.
If you want to pop it in the chat, that would be great.
Yeah, I'll show you the link to the, oh yeah, I'll do that.
And I thought Susan got hopped on and hopped back off. I know you've been in this for a long time.
Oh. Yeah, I Mostly I hopped on just to make a push for nucleic acid testing over culture, which is vastly superior. And then just to also make the point that the cost analysis that Elliott did is, incredibly thorough. So it does include, the rent for the footprint that the machine sits on. It includes the maintenance contract. It includes, everything. So I think I think following it up with Nettie's suggestion of the potential manpower savings, person power savings that would be achieved by not requiring personnel to call back people for treatment is a very good idea, because that might actually offset the cost associated with implementation of the test. And I think we ought to look into that.
And we can share a Robert Dice, or sorry, a Bobby D anecdote of just doing something right now. And I mean, to me, this is a total underestimation, but I think it's a great point of he's probably already, they're 20 minutes deep into this. And again, I mean, and how many of us have dealt with, so to Darcy's point, even with the chlamydia, you send the prescription, wait, that wasn't the pharmacy I wanted you to send it to, and the message back, and then you're sending it to this one. And then, Nettie, your office is tracking to see if they actually took it. I don't believe I'm not sure if a lot of offices are doing that. I think it depends on the patient and all of that. But that would be a great additional thing, and all of these things just take time. So, I mean, I think the argument is great. To me, it comes back to insurance in a huge
And
way.
whose time is it? Like the doctor time, our time is lunch hours and weekends and nighttime, of course, and nobody really wants to account for that. So, I mean, partly it's that a lot of the time is invisible time, right? That just gets piled onto the other, all of our extra time that we give. But, so the provider time, hopefully someone would actually account for that. But, I think nursing time is also easier to account for because they're hourly and you can really see it. 20 minutes or half an hour of nursing time is a big deal.
No, I think trying to figure out doctor or provider time is really important too. For me, a prep clinic on Friday, I'm spending a lot of the weekend dealing with STIs and messages to patients. And it all needs to be accounted for. So I don't know, Elliott, is this something that you want to try to figure out if there's a way to do this at, either the Owen Clinic or Federally Qualified Health Center?
Yeah, no, I mean, I think I'm poised to do it.
Yeah,
so it
I
makes
think
a lot
it'd
of
be
sense
great.
to me. I mean, people have definitely, this has been, the time spent doing all of this has been looked into, but this cost part of it is what's lacking that I don't think exists. So it definitely is something that would be beneficial. And again, it's like when you're wanting to implement or affect policy change, it's one thing. Everybody wants to report the public health benefits, which is great, but you really do have to talk about the costs in order to make kind of big changes like this. And I think that's a lot of what's lacking. So yeah, I'm set up to do it. I would be happy to.
And Akila just made a comment. It would be great if more treatment could be offered in clinic prior to discharge. And the UCSD Express Care is good about this. I think the problem I totally agree. And I think we're probably preaching to the choir of people who really make sure, if treatment should be offered and given, we probably do it. I know, at least in my experience, people who have frequent STIs, sometimes they just don't want the treatment then and there, and it's hard to convince them. They'd rather come back. And then you offer them some treatment. I don't know how many, people have dealt with the trifecta, where you end up having all three and you treated for the symptomatic, the rectal symptoms. So you've done that, but you still have to bring them back for penicillin. So it's tough. And I agree. And this is probably, again, more outside of clinics that do this a lot, is talking about treatment before, but then it gets into, the whole issue of, antibiotic resistance and treating unnecessarily. And will patients accept something if they're totally asymptomatic? I hope that, everyone's treating when someone's symptomatic or has an exposure. But
Yeah, and that's something
I'm
I
doing
didn't
a lot
really.
of talking. I'm very passionate about this. Go
No,
ahead,
that's,
Elliott.
that's something I didn't really go into, but I mean, that's the thing, right? Asymptomatic people, we're not going to usually empirically treat. And there's definitely literature showing kind of you get into antimicrobial stewardship, and that's an issue in and of itself. So better to have an actual test result quickly and get these people treated quickly than just giving everybody empiric therapy. I think there's costs with that too.
And Susan made the comment, New York City Health Department has made the decision to scale up gene expert testing in their sexual health clinics at scale. Would be helpful to find out how they're getting this reimbursed. All right, Elliott, on your to-do list. No, I'm just kidding.
That's if anyone let's circulate it. I mean, we can all do our little bits here and there to find that answer, because there are, I mean, it really is going to come down to just a lot of sort of the bureaucratic reimbursement part of it, because the patient maybe waits a little bit of time, they get their treatment right away. That's reduced transmission of STD, possibly reduced transmission of HIV, better patient care and customer service, and staff time saving for me. So I actually really think that probably when you look at that $5 to $10 that you came up with, and then you look at the other stuff on the back end, and it might be even at least a wash, and certainly better. So I think it's worth some lobbying on our part to try to shift this to be more standard of care. I think the data is pretty supportive that it's probably good for patients and for STDs in general, and I think it's better for the rest of us too.
Yes.
And Nettie, you just raised another issue again of the treatment guidelines changing from azithromycin to doxycycline. And I think a lot of us are struggling with that, because even, for us, sending a doxycycline prescription down 3 floors to our pharmacy, patients don't always get it. And so that has become harder. And I'm glad that your clinic is working on trying to get the 14 tablets in clinic and dispensable. I don't know if anyone from our clinic, I'm looking to see, I see Carrie and Lucas.
Just to be clear, we have a Zithro in clinic for clinic dispense, because we have a lot of clinics, they don't all have a pharmacy associated. Right. So if you've got your list of clinic dispense medicines, one of them is a Zithro. It's better if you send it to the pharmacy, because those clinic dispense medicines are some cost for the clinic. Nobody's reimbursing for them, because it's like doing a point of care test. So that's also really kind of unfair, but it's better for patients. You know what I mean?
Yeah, Jill, we've investigated that for Owen almost immediately when the guidelines changed to doxy to have the full course to provide in clinic, and it brought up a lot of issues with it. It's almost then like that the clinic is dispensing a prescription, and it has to be patient labeled and all of these other things. So we got a lot of pushback against it. So not quite the same situation as giving a single dose Azithro in the clinic.
Hey, Jill, it's Edie Seville. At Family Health Centers, we have doxycycline in the clinic that we can dispense to people who are on FPACT. But we can't dispense it to people who are not on FPACT, because FPACT pays for it and insurance doesn't.
So is it in a little prescription bottle, or?
Yes, little prescription bottle with a little label. It's all pre-labeled and everything. We have 7 days and 10 days.
Well, that's good, but it does seem like you got to change your, at least based on Susan's data, from culture to nucleic acid test.
I started there 6 years ago, and for 6 years they've been telling me they're going to do that.
Yeah. And what do you ask?
Can you tell us how did you have FPAC pay for them beforehand for clinic dispense, or do you submit a bill? Because I'm confused about that.
I'm guessing they submit a bill, but it's listed in our order set that you can dispense doxycycline for FPACT only. And I checked on this because our clinic has been dispensing it to everybody. Nobody ever told me FPACT only until about a month ago.
And I think only those who work in federally qualified health centers even knows what FPACT is. So thank you, Darcy, for putting in some information into the chat. Does anyone else have any comments?
I was just going to add one more rather trivial comment, but I think the other thing that point of care testing would do would allow you to not treat those who are symptomatic who don't have STIs. So a small population, but not everybody. There's plenty of data out there showing that symptomatic treatment results in some level of overtreatment of people who don't have STIs.
That's a great point, Susan. Be curious about that data.
It'll be in Elliott's paper when it comes out.
Great. And I was going to say, not trivial then, a great point. All right. Oh gosh, and right now expedited partner treatment is coming up too. So many issues. I don't know if there's any, I don't think that can really be resolved with your point of care testing, other than knowing very quickly. Yeah, actually, no, it expedites what's happening for a partner.
Yeah.
But yeah. No, that,
You,
I don't know how you factor that in. Is that
if you know
something
the
all
source
talked
is
about?
not infected.
Yeah. Okay, well, this was awesome. Does anyone else have anything they'd like to add? Can we have a round on EPT?
Expedited partner treatment.
I
I was like, oh,
Wow.
Somebody
Actually, no,
said
thank you.
that.
I thought we were talking about isn't EPT the transportation? So many acronyms. I think, Winston Tillman is going to be giving us an update on the STI guidelines, and we will make sure, I don't know if he's on right now, that actually may be a good thing to talk about, because there is some commentary about expedited partner treatment in it, in the guidelines. So we can ask him about that. But Elliott, thank you so much. This really was great. Obviously, extremely thought-provoking and lots of great discussion. With that, we will let Elliott get back to studying for the boards. And also, there may have been a message in there about a keyboard for you. So stay tuned. I think you might have an email coming your way. See, this is why people present at high rounds.
Fantastic.
All sorts of things.
And it's not just the swag either, right? Our new swag.
Hey, please show the swag, because I haven't shown it yet. Can you show it really quickly in our last
I don't
minute?
know. It's our new, yeah.
So this will go off starting in 2022. If you present, you will get a beautiful, really, what's the name of the water bottle? What are they called again? It's not a Yeti.
H2Go.
H2Go. I wish Marvin was on. This was all Marvin's idea, and we'll tell you more about it when we implement it. But yes, everyone gets high round swag if you present. So, and that's funny. Someone just told me they're rescheduling their talk. It just means that you have to present in 2022. Anyway, so thanks everyone. We're really glad you joined, and we will see you next week. Bye-bye.